So, all right, so our thoracic vertebrae, our lumbar vertebrae, our landmarks, spines process, transverse process. In the cervical spine, spines process, or articular pillars. Transverse process, side of the neck, we're not palpating that. The rule of threes, that's just so you know where your locations are if you're working on where's the transverse process in relation to the spines process. So T1, 2, 3, they're at the same level. 4, 5, 6, spines process is dropping half level down. 7, 8, 9, it's dropping a full level down. Then 10, 11, 12, it's coming back up to the same side like lumbar. And the lumbar, they're all equal. That's just our landmarks, so we know what we're treating. Lumbar anatomy, I just said it. So these are all at the same level. You're getting a little thicker. Motion testing. I give you some choices. We can do big motion testing, where you're moving around an axis. Okay, here I'm moving around an AP axis. I'm moving around a transverse axis, AP axis, vertical or longitudinal axis. Or we can just glide along the axis. That's what I did up here for side bending. It's what I'm going to do in the thorax. I'm going to do a little bit of glide. Why? It's hard to localize just to one segment. I'm going to use a little, I think, an easy shortcut. I learned to do these diagnoses in a very laborious way, the way we learned it in school. And one particular teacher gave me this caveat, which I'm going to pass to you. And that is, in theory, you said that triad-type motion, side bending rotation to the same side. Okay, that motion we call type 2, I'm sorry. Type 1, rotation side bending to the opposite side. So in theory, type 1 restrictions are in a group. I do this, it's a scoliosis, it's a group. The books say treat the apex of the group, the middle spot. Type 2 lesions, side bending rotation occurring to the same side, you cannot have them next to each other. You can't make the spine do that. You can't make the flexible spine do that. I can't make your spine do it without something that's fractured, something like that. So we're looking for an isolated single segment dysfunction. So I have to start somewhere. So I'm going to start with my idea that I'm looking for a single segment that's a problem. If it's a single segment type 2 dysfunction, and don't freak out if you forget all this when the patient's in front of you. I'm looking for a single segment dysfunction. I'm going to make an assumption that it's flexed or extended. Rotated side bend, but it's flexed or extended. 3 planes. So I'm going to go in the interspinous spaces, where the patient says, you know, I got pain around here. You're not going to check their whole spine. You're going to check close to it. So I'm going to look in the interspinous spaces till they go, ouch. My thought is that that space has been either narrowed or stretched. Not on the radiograph. On a radiograph, they can look a little different because you're not built with Lego blocks where the distances are all even. In a normal situation, you're not built that way. But from whatever the normal is, if it's stretched, I could say the segment above is doing what? See, you thought you didn't have to answer until 5 minutes from now, so your brains are on hold. One day I hope to hear what he says to me. The mouth is moving, the fingers are going, everything but the voice. If this is stretched, the segment above is doing what? You got a 50. Did you say side bending? Flexion. You get why that is? This is all academic, we're making this up. If the space is increased, either this one has bent forward, this one's bent forward, or the other one's bent backward. That's what it is until it's proven wrong. One of those 2 segments might be the problem. So this is the only time I think pain is helpful. I find the area that hurts the most, it's one of these 2 segments. And then I can make my tests for side bending. Rotation is a static test. I feel which transverse process is posterior. This is my little rapid pain localization, Dr. Sennett's super secret ninja technique to do things quickly is you go ow, and and then I go above or below, 1 or 2, 1 or 2, 1 or 2, 1 or 2. And it not always, but generally speaking, let's say I have multiple problems. Generally speaking, if this is the problem, is if I get closer to this, the pain is more and more until I get away from it. So it's a quick way to localize the segment. So I need to make a mechanical diagnosis. There's subjective complaints. The subjective complaints are why they're paying you money. I have this problem. Always remember, the pathway to fixing the problem, they don't know. Either does the last osteopath, chiropractor, acupuncture, no one else, just you. So you can be confident in taking your own swing at the ball. The wicket. Sticky wicket. I'm not quite ready to give up on humor with you people. I'm very close. I'm a little depressed. Right? You're not laughing, but I'm not ready to give up. I want to share with you a very nice smile. But when you're not smiling, I'm a little frightened because I don't know what's going on here. It's like that stone face. I suddenly feel like I'm in trouble. I said the wrong thing. She said, tell my teacher I'm all kinds of trouble. Tell my mother. So I got to make a diagnosis, subjective complaints. The history, I take the history. What happened to you? You need to make a medical note. Is that telling me how to proceed? No, it's not. The history, no matter what, it's never going to be 100% complete. People leave things off. That's why I told you I'll go through their vitamin bag. What do you take this for? They suddenly tell you something else. So I get what I can. Realize people are not coming in just with a back problem. They're coming in with a bunch of things that are now compensating. Even if it's acute versus chronic, there's a bunch of things going on, contributing factors, and what the pain feels like to them. As far as mechanical compensatory changes, I think I gave you an example before Khadija falls over, and that was, if I say my lumbar spine is turning a little bit this way, obviously, the neck's going to do what? Going to do that, because 80% of your neurology is dedicated to vision. And the level world is real important for you. This person might come in complaining of neck pain all the time because the neck's got to compensate. You treat their neck, you do whatever. Why is it? What problem's down here in the lumbar spine? If the lumbar spine wasn't a little off, their neck would be off. But the lumbar spine doesn't hurt. If I got to hammer into your heads the last time, they can tell you what's hurting. They cannot tell you what's causative. What's causing pain? Pain's complicated. There's a bunch of, we can add more to this list of things that get released when you have edema, histamine, and so forth, the cascade of painful hormones. This is probably a recap of what I did when we first met in a different way. If I say pain is multifactorial and you have a herniated disc, L5, would you agree with me that if L5 is herniated, that neural foramen is compromised, the space? Would you agree with that? This is the part where you say, yes, I agree fully. Okay, 3 of you agree with me. Would you agree that there's some edema? Yeah. Are they having painful neurotransmitters? Probably. Spasm? Probably. Can you control their work factors and social factors? No. Can you bring down their anxiety if you bring down their pain? Can you change edema? Spasm? Reduce painful neurotransmitters? A lot of that, yeah. That can make their pain either completely go away or be a big factor. That can get them sleeping better, break down the anxiety. So, this was another picture that I had for you guys. Just showing you, if everything was fine, your whole disc would be red here, ready to compensate for the world. And you keep losing chunks of it with the different problems that are happening. And I just made these numbers up. I just made it up. I said nerve compression is 15%, spasm 10, edema 10, pain 10, anxiety. I made up all these factors. You don't have to make everything go away. You just have to get them back to half of it go away. And they still got problems, but they're not perceiving any pain. There's people walking around, and probably people in this room. I have 2 bad discs in my neck. I got 1 for sure, maybe 2 in my back. My neck's not bothering me at all most of the time. I'm on the wrong kind of pillow, changing hotels. My neck hurts, and the air conditioning's too much, and then I get a headache. But most of the time, I'm okay. I don't know if I had torn my knee when I saw you last. That happened in Saudi Arabia, because I came in with the cane for everything. Fixed itself, because I've been a good boy most of the time. So, I can afford surgery. I don't have the time for it. I'm flying everywhere. And I was starting to get a little bit depressed about it. It was really bad when I saw you guys. And then about a month ago, I stopped thinking about it. That's what happened to me. I did this before in Ethiopia. I stopped thinking about it. I'm like, I feel okay. You can heal. Even if you're my age, 107, you can heal.